بسم الله الرحمن الرحيم. أنا دكتورة سمية متولي. أنا Head of Physics Unit عين شمس University, Department of Radiation Oncology. Our talk today about some principle or physics of brachytherapy. Let me first give a brief introduction about brachytherapy. Brachytherapy is a modality of radiotherapy, and it's considered a very important modality. In recent publications, mentioned that brachytherapy is now considered 50% of all treatment of all cancer patients treated with radiotherapy is treated with brachytherapy. Also, brachytherapy has been used over 100 years ago. And of course, there's a lot of development occurred in the users of sources and also the brachytherapy machines. Previously, brachytherapy referred as a cryotherapy. This is very old definition for brachytherapy. And also brachytherapy is defined as it is a short distance treatment of malignant disease with radiation emanating from a small sealed or encapsulated sources. The sources are placed directly into the tumor treatment volume or near the treatment volume. So external beam radiotherapy versus brachytherapy. External beam radiotherapy, of course, it is obvious that the source of radiation is outside the patient, and we have examples for external beam, X-ray tube, cobalt-60 teletherapy, and also linear accelerators. Brachytherapy, as it is obvious from the figure that the sealed sources inside the patient, and we have multiple sources, radioactive isotopes. The very famous number are cobalt-60, cesium-137, iridium-192, and iodine-125, and palladium-103. Brachytherapy compared to the external beam therapy. What is the advantage of brachytherapy? Brachytherapy actually improves the localization of the dose inside the target volume, and this is a very important advantage actually. Another advantage is the sharp dose fall off outside the target volume, and this is, of course, as you all know, that spares the critical structure besides the tumor. Also, brachytherapy considered as it is give a better confirmation therapy. What is the disadvantage actually of brachytherapy? It is only for good localized tumors, small tumors. This is disadvantage, as we all know. And also, it is only good for small lesions, and it make a lot of steps. What is the brachytherapy sources? We have different sources. Of course, it depends on the emissions of particles. So we have photon sources, and in these kind of sources, gamma rays emit through gamma decay, and some occasionally there is also a characteristic X-ray may be emitted through the electron capture, which occur in during the internal conversion in the fission processes. Some examples for photon sources are cobalt-60, cesium 137, iridium 192, iodine, palladium 103. Okay, we have also beta sources which emit electrons from beta source decay. Example is strontium 90 and deuterium 90. Neutron sources emit neutron following by spontaneous nuclear fission. Example is clavorium 252. Types of brachytherapy implant. We have 6 types of brachytherapy. Intracavitary, and in this kind, in this type, sources are placed into the body cavity. Interstitial, which means sources implanted into the target itself. Surface plaque, which what happened in surface plaque is the source are loaded into plaque, which brought into contact with the skin surface. Very famous type, very famous kind, especially in retinoblastoma, this type of brachytherapy. Intraluminal, in this type, sources are inserted into the lumen. And intraoperative, which sources are brought surgically into or near to the tumor volume. Intravascular, in this type, sources are brought intravascular into the lesion or near to the lesion. Brachytherapy classification with respect to the treatment duration. We have multiple classification of brachytherapy. This is one of them. We classified brachytherapy based on the treatment duration. We have temporary implant and permanent implant. In temporary implant is a dose delivered over a period of time that in short to comparison with the half-life of source. This means that the source we enter the sources inside the patient and until we finish from the dose per fraction, and then we remove the source to the machine. Sources are removed when the prescribed dose has been reached. And this is nowadays use this kind of brachytherapy. Permanent implant means the dose is delivered over all the lifetime of the sources. The sources undergo complete radioactive decay, which means as a source or the sealed inserted to the patient, and the patient go to his home, and the source completely decay inside the patient. So this is permanent implant. Brachytherapy classification with respect to source loading, how we load the source to the patient. Actually, we have hot loading. This hot loading means the applicator is preloaded. We have the applicator in our hand and put the sources in the applicator, then we insert it to the patient. So the other one is after loading. After loading means the applicator is placed first in the patient and then the source enters the patient. And this is, of course, occur or happen easier by hand. This is manual after loading or by machine, and this is automatic remote after loading. And this is the type of brachytherapy we used to do now. Manual after loading. Generally, the radiation sources are manually after loaded into the applicators or the catheters that have been placed within the target volume. At the treatment, at end of the treatment, the sources are removed. Again, this is manual. Manual loading, of course, as it's very obvious that in the manual loading and the removal of the source from applicator or catheters result in some radiation exposure. هو مش some والحقيقة exposure, very high exposure to the medical staff. Manual after loading, and this is في الصورة في المانيوال هوت لودينج زي يعني السورس بيتمسك بالنكد hand يعني it's very risky الحقيقة. And we have manual down here, manual after loading, which means we insert the applicator first inside the patient and then insert the source. Remote after loading, after the development of brachytherapy machines, now we have computerized system. Actually, we have a remote after loading system, and this is nowadays heavily used. يعني. In this kind of treatment, we use remote after loading machines, offer these several practical advantages over manual procedure, such as increased patient treatment capacity. By using this kind of brachytherapy, we have time to make a number of patients, because the manual loading for the sources take a time. So you can't make maybe 1 or 2 per day, but we have now, after this development, we can handle maybe up to 8 patients per day. This is one of the advantages of the remote after loading. And also one of its advantages is reduced radiation exposure to the staff. These images is historical development for the machines. Cobalt Ralston, the diameter of the source was 3 millimeter. In 1990, iridium 192 diameter source 1.1 millimeter, and 2000 cobalt rails the diameter 1.1 millimeter. Sorry. We can classify brachytherapy again with the respect of dose rate. So we have low dose rate, and the range is started from 0.4 up to 2 gray per hour, and we have also very low dose rate. Less than 0.4 2 gray per hour is considered as very low dose rate. Medium dose rate, it's starting from 2 up to 12 gray per hour. High dose rate is bigger than 12 gray per hour. Pulsed dose rate brachytherapy, it's very famous kind of brachytherapy and used nowadays a lot. Actually, in addition to low dose and medium dose rate and high dose rate brachytherapy techniques, another type of after loading brachytherapy has been developed, in which a continuous low dose rate. It is a continuous low dose rate treatment, and it is stimulated by series of short duration dose pulses of the order of 30 minutes, separated by interval of 1 to several hours of no dose given. This is technique to give pulsed dose rate, but actually there is a machine. There now machine make this automatically without giving this treatment by this way. Technique is referred as pulsed dose rate brachytherapy. So now we have another development in brachytherapy, what is called electronic brachytherapy. So what is electronic brachytherapy? We can define electronic brachytherapy as it is a form of radiotherapy, and it is delivered locally using miniaturizing electronic X-ray source rather than radionuclide, or rather than a radioisotope-based source. So we don't have any isotopes. So electronic brachytherapy use miniaturized X-ray sources. It is an X-ray tube or miniaturized linear accelerators inserted to the instead of radionuclides to deliver high dose of radiation. The advantage of electronic brachytherapy include low dose of course, to organ at risk, and it's very important. This is the main advantage, and also reduce dose to the training stuff. No leakage radiation in off state, and also less shielding. I don't need to make shielding for the room. No radioactive waste. I don't have any waste because I don't have any radioactive isotopes, and don't need to transport this radioactive isotope from place to the treatment machine. What is the rationale for electronic brachytherapy? Actually, the International Commission of Radiation Protection, ICRB, published a report in 2005. This publication reviewed that in all the radiotherapy accident associated with high dose rate brachytherapy, we have about 500 accidents. One of them, it lead to death. So it's very actually dangerous. rationale for electronic brachytherapy. Electronic brachytherapy system don't emit radiation in the off state, of course, because we have X-ray tube inside the machine, which eliminates likely accidents with source packaging, transportation, and mishandling of source related to radionuclide brachytherapy. They can be operated in standard treatment room. أي أوضة ممكن يتحط فيها الجهاز اللي فيه لأنه يعتبر mini linear accelerator. أنا عندي mini X-ray tube محطوطة في ماشين ب low energy, so I don't need to a specific room, I don't need to banker, I don't need to shield. So there is also no radioactive waste. This is very يعني big issue في البراكيثيرابي. And hence no concern with the source transportation. Unlike radionuclides, which require a special license for source transportation and radioactive waste disposal. Electronic brachytherapy machine, as you see, this is the small X-ray tube. This is inserted in a specific machine, and after that, we connect this machine with the patient by transfer tube. Different type of electronic brachytherapy system are available. Most of these systems operate between 50 to 100 kilovolt. So I can, by this energy, I can replace iridium 192 high dose rate brachytherapy. The X-ray source is inserted into catheter implanted in the tumor, much like how high dose rate is administered. زي بالضبط ما بشتغل بالهاي دوز rate machines based on radioactive isotope source. بنفس الطريقه بالظبط انا بعمل انسرشن للاكس راي جوه الابليكيتور جوه العيانه. Electronic brachytherapy have wide variety of applicators. Yes, there is a specific applicators for electronic brachytherapy, and also we can apply on multiple sites electronic brachytherapy. This is the details of the tube. And this is a number of machines. Actually, it's very famous now, and I think it is very promising. Example for electronic brachytherapy applicators. We have Palion applicators. This is spherical applicators, and also we have vaginal cylinders بدifferent sizes طبعا على حسب anatomy patient, and we have a skin surface applicator. This is multiple. I have a variety من applicator, so I can use it for different sites. This is a very this is a comparison between radionuclide and the electronic brachytherapy. Actually, both have advantage and disadvantage. Regarding the advantage in brachytherapy with radionuclide, we have a small source, a fixed energy spectrum, easy to predict the output of any point in time using half-life, used in combination with external brachytherapy alone, or rapid dose fall-off, lower dose to organ at risk, proven clinical application, and well-established protocol and treatment procedures. What is the weakness or disadvantage of brachytherapy-based radionuclide? It's radiation leakage, of course. It's radiation leakage of condition, and also radioactive waste. This very big concern, especially in our country. Frequent source replacement. If you have iridium source, you have to replace your source after the half-life, and the half-life of iridium 192 is about 2.5 months. So you have to replace the source each 2 or 3 maximum or 3 months. You have to replace it. Okay, and this is very big issue. Source transportation related radiation accident, of course. This is the main problem. If you have an accident, when you transport your source, it's very big problem, actually. What about electronic brachytherapy? Electronic brachytherapy, طبعا we don't have any radiation leakage because we don't have any exposure. User adjustable energy. The machines can adjustable the energy and the dose rate. No radioactive waste. Source transportation, not an issue because we don't have any source. Okay, what is the weakness في الالكترونيك brachytherapy? Relatively large source size. التيوب X-ray tube considered as a large source size, limited treatment sites compared to nuclear brachytherapy, minimal experience compared with nuclear-based brachytherapy. But هو الحقيقة في researches جديدة وبابليكيشن كتيرة على الالكترونيك brachytherapy recently. Clinical applications, we can apply electronic brachytherapy in all sites: breast, skin, keloids, spinal, metastatic, gyna, endometrium, cervix, and rectum, because we have a lot of variety of applicators. So now, brachytherapy. Quality assurance of brachytherapy is very, very important task. Complete set of procedure. Quality assurance for brachytherapy machines is considered it as complete set of procedures that are undertaken to ensure that the treatment is delivered according to the intent of radiation oncologist to deliver your prescribed dose as the oncologist described. The state of federal regulations of brachytherapy will American Association of Physicists in Medicine, AABM Task Group TG reports. If you wanted to make some reference, about the electronic or also brachytherapy, you have to read this reference, AABM TG reports, and then a TG 43 about those calculation in treatment planning. TG 53, QA for treatment planning system, TG 59, safety aspect of brachytherapy treatment, and TG 186, advanced dose calculation. Quality assurance taxonomy. Of course, we have to classify or divide the quality assurance because we have a lot of stuff to do. We have applicators, we have afterloaders, which are the machines, we have source, we have planning system, and this is all connected to each other. So are you happy with your machine? You have to make this quality assurance or this classification of quality assurance before you start to use your machine. You have to make commissioning and acceptance test. You have to identify malfunction and test user by yourself before you start to use your machine. Transform physicist into expert user. You have give your physicist and training for how to use this machine, and also how to calibrate your machine before you start to treat patient. Integrate device into clinical program. You have to enter your machine to a specific program for quality assurance. You have to do this procedure before you start to treat your patient. Patient-specific QA or process of QA. This is described in TG 56 for low dose rate and the TG 59 for high dose rate. All quality assurance exist in these two task group. During individual patient treatment, prevented treatment delivery error and high risk scenarios. You have to do this kind of all quality assurance before you start to use your machine. Accurately deliver dose distribution, desired by a radiation oncologist, of course. Clinical intent to correctly translate into prescribed dose and normal tissue constraints. Spatial temporal accuracy, correct source placed in prescribed location for prescribed time. You have to do some steps when you make first. When you start your day, you have to calibrate or make some quality assurance for your machine. The afterloader itself, you have multiple interlock. You have to check the position of the source when we moved inside the transfer tube. You have to check it. You have to check the door closed. You have to check the sound inside the room. You have to check a lot of interlocks regarding the treatment room. A specific endpoint with the positional accuracy. You have to check this by, nowadays we have some camera, this kind of camera connected with the afterloader, and you check the dummy source, of course, not the actual source. You check the position of the dummy source by using this camera, and you have also, you have only plus or minus 2 millimeter shift. This, if more than that, you don't have to use the machine. Safety endpoint also, protect the staff and the public. You have to give your staff radiation protection lecture. They have some awareness about what is uncontrolled area and what is controlled area, and general public. These limitations also is published in ICRB, International Commission of Radiation Protection. So the uncontrolled area, it should be less than the dose or the exposure. The background of uncontrolled area, it's less than 0.02 millisievert per hour. General public, less than 1 millisievert per year, to any person. This is limitation of the exposure. And also for the staff, less than 5 millisieverts per year as per ALARA. ALARA is the principle of radiation protection, and it is mean as low as reasonable achievable. Protection patient from catastrophic error. This is safety endpoint. You have to make sure that every step you go on in treatment with brachytherapy machine, you have to check and we have to verify all critical decision point, verify interlocks regarding the afterloader machine, emergency and error recovery procedure. You have to make your plan for emergency if there is any accident happen, like stocking the source inside the transfer machine or inside the patient. This is very big issue. Okay, you have to complete the, of course, the records for each patient. This is also quality assurance procedure. Thank you. Any question?
Thank you, Dr. Sumaya, for your nice presentations. Thank you. Now we can open the floor discussion. Any questions? Okay, now let's move to the next presentations. And I am with my pleasure to introduce our dear professor, Amin Said. Professor Amin Said will give a presentation about the submission for EBRT and DBT in cervical cancer, radiobiological considerations. Thank you.
Bismillah ar-Rahman ar-Rahim. Okay. Actually, before I start, when I got the agenda from the organizers, and I found that I have two presentations in the same day. One of them is in the morning for 2 hours as a workshop, and the other in the evening for 20 minutes. I try to make them as short and as simple as possible. Therefore, I will try to be very, very short and very simple in this presentation, and I will avoid any complicated mathematics. Actually, in the beginning of using brachytherapy, low dose rate was the common one, and most of the calculation or all the calculation, especially as Dr. Christine showed us in her presentation, is in the point A according to the Manchester system. And it was easy to do the summation by adding the external beam dose to the low dose rate brachytherapy dose. And after that, started to use the biological dose. And actually, in the beginning, they used what is called CRE model, and it was a power empirical model to convert the physical dose into a biological dose from both the external and the brachytherapy, and to add them together. After that, the linear quadratic model has been introduced, and a lot of actually of models has been reported or published after that. Branson in 1982 start to use the linear quadratic model for external beam radiotherapy, and Rogersdale, and he was my examiner in my PhD thesis, published a lot or a series of papers regarding the calculation of biological effect from brachytherapy for different dose rates, not only low dose rate or high dose rate, for any dose rate. And he used in his equation or his model the dose rate as a factor in that model. But actually, after the introduction of the modern radiotherapy using high dose rate, most of these model is now not in use. We are using a simpler models, or are using what is the BED equation. And actually, Dr. Christine talked about EQD2 equation, or how in most of her presentation, she calculated the dose using EQD2 model equation. And actually, the EQD2 is and the BED, which I will use in my presentation, it's the two faces of the same coin. They are almost one thing, but the only disadvantage of BED is its odd value. It's higher than what we are commonly use. If for example, I use 50 grays in 25 fractions for treating a patient by external beam radiotherapy, if I calculate the BED, it may be over 100. But when I convert it to EQD2, it will be almost the same as what we use in the clinic. Therefore, I will use here the BED because of only one thing. The BED can be, or we can add another term to the BED equation to allow calculation for different dose rates if I want. But if I use only a high dose rate, I don't need to add any dose rate factor in the BED equation. After the introduction of, or after the development of medical imaging and the volume imaging using CT and MRI, and almost in the same era, new techniques in external beam radiotherapy has been introduced like internal IMRT and VMAT. Therefore we had or the people at that time, or the radiation oncologists at that time, had to move to doing, instead of point calculation, a volumetric calculation to do to calculate the dose in a volume, not only in a point. But the problem in the volume calculation is that we didn't have we considerably have a spatial and geometric dose heterogeneity. In radiobiology, or the radiobiological factors the factors which may be the radiobiological effect of brachytherapy are the dose rate, the fraction size, and the absorbed dose distribution, and the treatment time, and interfraction time. The BED is one shape of the LQ model. It has been driven from the LQ model and take a certain shape, as we will see now. And it's, as I said, it's another face of the same coin as EQD2. A lot of reports recommended to use the BED to allow us to do the summation of external beam radiotherapy to the brachytherapy for high dose rate. Usually in the BED calculation, the BED parameters which has been used was alpha over beta equal 10 for tumors, and alpha over beta equal 3 for late responding normal tissue. And this is a very critical point, actually, because these values are not, as we thought, it's common. No, it varies from one tumor to another, and from one normal tissue to another. And if we use these values for all tumors and for all organs at risk, we will get a lot of problems in the outcome of the calculation. The T-half or the half-life of repair half-life was considered also as 1.5 hours, and these values can be converted into, or using this value, we can convert the BED to EQD2. BED can be used for ISO effect dose calculations, but we have to know the exact value of alpha over beta ratio. The problem of the BED is that one of its limitations is that it doesn't take in account the overall treatment time and the interfraction time. Although we converted the BED in external beam radiotherapy calculation, as we saw in the morning. If anybody attended in the morning, except only Dr. Mohammed Sadi is the only one attended in the morning. We talked about adding the time factor to the BED, but we do that for external beam radiotherapy, but we don't do that for BT. If we want to do that for the BED, we have to go back again to Dale's or to Rogers-Dale's model, or to any other model like which take the dose rate in account. And actually, this is very important because we don't only do that calculation for brachytherapy only, but we do that also for targeted radiotherapy. In the radiobiological calculation of targeted radiotherapy, we have to add the two parameters, not only the dose rate, but the dose rate and the range of the emitted particle from the radionuclei. This is the shape of the BED equation. We just divided the E value of the linear quadratic model by alpha. BED equal E by over alpha, and this will be the final shape of the BED. This is the only mathematics in the presentation. I'm trying to avoid any repetition. The only problem of that equation, as I said before, it's very difficult to obtain the specific values of alpha over beta for each tumor or for each organ at rest, especially, of course, for brachytherapy, especially also for using high dose, because when we estimate the alpha over beta values, or when we try to get the alpha over beta ratio from clinical data, we use some isoeffective schedules having the set of isoeffective means that have the same effect but different fractionations, and from them we can estimate the value of alpha over beta by plotting the total dose against 1 over dose per fraction. We can estimate the value of alpha over beta, but we will not find a lot of data for most of the tumors or for most of the organs at risk having large fraction size. Therefore, one of the limitations of the BED value is to use it for a fraction size larger than 6 gray. This is very important because we, as far as I know, we use in our department in Ain Shams is a fraction size of 7 gray. And this is not acceptable for BED calculation. Don't use BED for more than 6 gray. Otherwise, you will get some errors in the calculations. That's what I was talking about the fraction size. This is one of the most important limitation of BED calculation, not only the values of alpha over beta and T half, but also this point. So the problem, the limitation of the BED is that it doesn't take into account the tumor cell repopulation, and it doesn't take in the calculation the overall treatment time or the interfraction time, and also using this a certain value of 10 for tumors and certain value for of 3 for all organs at risk. This is also not recommended. We have to get the specific values of each organ and for each tumor. Also, another limitation is the spatial and geometric variation of those. So, as I promised, I tried to be very short. And the conclusion is that we have to find out the specific values of the parameters which will be used in calculating the BED, or of course for calculating the EQD2 to do the summation of external beam radiotherapy and brachytherapy. Thank you very much. معلش الحقيقه انا يعني حاولت اكون سريع على قد ما اقدر لان انا بنزيني خلص من بدري قوي الحقيقه يعني.
Thank you, Dr. Amin, for your focused and informative presentation. Any questions?
Actually, I have a question for Dr. Amin, if it's possible.
Okay, Dr. Hoda, sir.
Hello.
Dr. Amin, أنا هدى البوز.
اهلا يا دكتوره هدى، ازيك؟ عشان انا عمال ادور في القاعه اقول فين اللي بيتكلم.
Right, for those who don't know, actually, Dr. Amin is my teacher. And in fact, this is where all my love to radiobiology and brachytherapy has all started. So for those who don't know, you know, the history about me and enjoying brachytherapy, there is one thing that I wanted to ask you about this very excellent presentation. And it sums up, I mean, I can remember all these things, but one of the things I'd like you to clarify, there is a trend at the moment, especially in the UK, I don't think it's in Egypt, especially in the UK and Europe, because of lack of access to theater spaces, that high dose rate brachytherapy, traditionally, it's actually being used as 2 fractions per week. So there is a Tuesday and a Friday, for example, or a Monday and a Thursday, in order to allow for the repair and the repopulation. But now there is a trend of doing a single insertion and then keeping the applicator in for several days, for 2 or 3 days, and doing 2 fractions per day using the high dose rate brachytherapy. So very similar use to what the low dose rate used to be used. I just want to know whether you have any comments about this, because personally, I don't agree with this. Again, because of the radiobiological effect on it, but I wonder whether, what's your opinion about it?
Do you mean about using 2 fractions per day if in brachytherapy, or?
Actually, so with brachytherapy, you know, it's a high dose rate, and you're giving a very high dose, as in giving, for example, 6, 7, 8 gray.
Or your question about more than 6 gray?
No. يعني دلوقتي اللي بيحصل ان احنا الاكسترنال بيم راديوثيرابي هي 2 gray per fraction.
Yes.
Okay. Well, it's given once a day. Occasionally we give 2 fractions.
معلش الصوت مش واضح اصله بالنسبه لي، انا مش سامع كويس اصلا. الصوت وطي قوي يا جماعه، صوت الدكتوره هدى وطي. Okay.
Is the sound better now?
ايوه دكتوره هدى اتفضلي.
Sound better?
Better, yes.
Okay. So what I meant is, now traditionally the external beam radiotherapy is given 2 gray per fraction, or 1.8 gray per fraction, once a day, or sometimes twice a day if there is a 6 hours gap. The brachytherapy is being given as a high dose rate, so you're giving about 7 or 8 gray in about 5 minutes. And if we were supposed to be using it as once or twice a week. This is how high dose rate brachytherapy all started. My question is, what is your opinion about some centers, especially in Europe, for example, using the high dose rate brachytherapy, but actually multiple fractions either per day, so with a 6 hours gap, or using even following days, so they're not giving the gap in days, so using the high dose rate with the same principle as low dose rate used to be given?
Actually, as long as the interfraction time is longer than 6 or even 8 hours, no problem to use 2 fractions per day in brachytherapy. As also the same, because as I said, we use T-half of 1.5 hours. The half-life of half-time of repair. The half-time of repair, if the half-time of the repair is 1.5, this means that we need about 6 to 8 hours for to be as close as possible to complete repair.
The trouble is, I think all this data is interpolated from low dose rate. It was never done on high dose rates. My problem is that this is, you're talking about 6 or 8 gray given in 5 minutes. And we're still some centers using this as as a low dose rate. So they're giving it on, for example, 2 in a day with a 6 hours gap, and then the following day they can do exactly the same. So you're finishing about 28 gray in 48 hours.
Actually, my own opinion is that to do any radiobiological calculations, we have to take in account the dose rate and the
Yes.
all treat time and the interfraction. But to use that very simple equation, I don't think this is
Doesn't
the
work.
best solution.
Exactly.
But if
yeah.
we go back to one of Rogers Dale equation or the similar models which taken in account the dose rate and overall treatment time and the interfraction time, we will be as close as possible to the right thing. But to ignore completely the time
Dose rate.
factor and the what's going on during the interfraction time and all of these parameters, to ignore them completely and use that simple equation, I don't believe that it's the right thing.
I
But
totally agree.
that's
yeah.
what is available at the moment.
Yeah, I mean, I totally agree. And it's because we don't have the evidence. I think it's very difficult. I think all the calculations, the historical calculations for radiobiology, for brachytherapy, was all done on low dose rate or medium dose rate, but it was never done on high dose rate.
Mhm.
So, okay. Thank you very much.
Of course,
Thank
we
you.
cannot use the same data of low dose rate to be applied to high dose rate, but we have to find a good solution for the right calculation of or the radiobiological calculation for the high dose rate. We
Yeah.
have to use a different model which take in account all of these factors. And of course, there are a lot of trials, there are a lot of publications around that point.
I think they all come to the end saying that this is actually was interpolated from low dose rates, and therefore it has to be applied with caution. You know, it's I think the trouble is most those who moved to use one insertion with multiple treatments are actually completely using it because of availability and accessibility to theater time, rather than that this is actually the right thing to do. So, which is what worries me, that we're actually using the tool of high dose rate, but actually treating in a very similar way how the low dose rate used to be done. Okay, thank you very much.
Thank you very much, Dr. Huda, and I hope to see you soon once you visit Cairo, you and Dr. Sharif.
Inshallah.
I will wait for you in Cairo, inshallah. Thank
Thank
you.
you.
Dr.
Thank you.
Yes, Dr.
Yeah, thank you very much for your very elegant and very.
No, it's not very.
It is, but I have. It's up to the point.
Yeah.
But I have some comments as a clinician. The alpha beta model, as you just mentioned, for tumor is 10, which is not 10. If
Yes.
I personally use the this very primitive. It's not primitive. This is the program sent to me by Withers very long ago, and I calculated the dose. I mean the alpha beta model, and it comes as 12 with the 95 confident interval from 5 to 120. So that is very huge.
Yes.
The same is the T-half. T-half, we all consider it as 1.5 hours. But again, sometimes it's half hour, sometimes it's 2 hours. Although the EQD is QD2 or BED, are very practical, or we can say simplified way to use the problem, to solve the problem, our problems. But still there is a way to go in order to specify in one way or another. I don't know how, but this is, I believe this will occur in the futures. As I am an old man, we used to do the LSD and CRE for very long time. And it was working for some patients and it doesn't work for others, or didn't work for others. So we shifted to the more realistic LQ model. And I'm sure that we will have another until we get this. The point that I want to emphasize that the clinical judgment is extremely important. This is a useful aid, and what we can calculate and what we can estimate, but still the judgment, the clinical judgment is extremely important. And sometimes you get something very odd with the number. You have to ignore this and use your clinical background and clinical judgment. Thank you very much.
Thank you very much, Dr. Mohammed. Actually, what Dr. Mohammed said, exactly what I wanted to say during the presentation, that most of the available data we have at the moment, or we use at the moment, is not the precise data. But that's what we have. But today, when I was talking about values of alpha equal 10 or organs at risk equal 3 or whatever, because I was concentrating on gynecological cases. But if we talk, for example, like in the morning, if we talk about prostate, the alpha over beta value of the prostate is 1.5.
And even
how
within
can
the
we
same
compare?
tumor, within the same tumor,
Yeah.
if you experimented and get the alpha beta model, this, yeah, you can never have the same results for each patient.
Yeah, and
but it's average.
And as you know, Dr. Mohammed, even the alpha over beta value, if for very long period of treatment, if you use for example 5 or 7 or weeks for prostate, for example, the value of alpha over beta changes due to mutation. The tumor mutate during the treatment, and the values of alpha over beta changes.
I'm sorry to interrupt, but actually nobody ever also did the correlation between the grade of the cancer and the alpha over beta ratio. So simply we only had cervix cancer, for example, or cervix have this alpha beta ratio, but in fact it doesn't, because you're absolutely right, Dr. Mohammed and Dr. Amin, that actually it depends on the cells and the mutations and the aggressiveness of the cells themselves, which is what we call in pathology the grade of the disease. So so there are cancers, for example, like the grade 1 cancers, they certainly don't have the same alpha beta ratio as the grade 3 cancers.
أنا مش سامع صوتك كويس الحقيقة.
She emphasized the idea that if you have a high grade and more aggressive tumors, you get alpha beta ratio is different from those with lower grade.
Yes, of course, yes.
Yeah. So we all agree about the concept itself.
Yeah. Okay, Dr. Hussein. Any more questions? Okay, thank you very much.
Now we will have a lecture for Dr. Bolek about does your brachytherapy equipment do what you expect it to? Hello, Dr. Bolek. Okay.
I'm Wojciech Polak, and I'm head of brachytherapy at Queen Alexandra Hospital in Portsmouth in UK, and I'm also an honorary lecturer in the University of Portsmouth. I worked in radiotherapy for the last 15 years, and in this talk I would like to show how important it is to know equipment we work with. And I know when physicists mention quality control, most people just think, oh, not again. That is so boring. But I try to make the talk interesting with lots of pictures and examples of our clinic as well as from the literature. So, does your brachytherapy equipment do what you expect it to? So, why do we need to know? Well, if we don't, incidents happen. So, just a few examples of the incidents. So, for example, in Edinburgh, in 2015 in the UK, patient was overexposed during the radiotherapy treatment, receiving 100% more radiation than intended. And the root cause of this was human error, lack of training, and lack of independent checks. In Princess Margaret Cancer Centre in Toronto, in Canada, nearly 1,000 patients had received underdoses of radiation during treatment. And the reason was that a computer programming error in the treatment planning software was not actually spotted during the commissioning. So again, inadequate commissioning and the lack of independent check was the cause for this underdoses. Another one in France in 2006, where actually physicists and clinicians were jailed for manslaughter after exposing 29 patients during the prostate radiotherapy treatment. And again, root cause was human error, incorrect commissioning of treatment planning software, lack independent check and audit, and in this case was also trying to cover up the error instead of actually admitting that something like that happened. Okay, that was external beam. Surely brachytherapy is far less complicated when it comes to equipment. Maybe, but it does not mean that the incidents won't happen. And we do have some examples in brachytherapy as well. So, for example, in Memorial Sloan Kettering Center, Cancer Center in USA, 6 patients were overexposed to radiation during the brachytherapy treatment for prostate cancer. And again, human error, incorrect commissioning, lack of audit, and not following the safety protocols were the root causes of that incidents. The bigger one was in Japan in 2013. 100 patients at the hospitals were overdosed during the brachytherapy treatment for uterine cancer over a period of 7 years. And the overdoses were caused by an error in the input channel length for the applicator, which resulted in treatment being performed 3 centimeters off the tip of the ovoid applicator tip. The overdoses ranged from 1.2 to 5 times of the intended dose. And as a result, 15 patients developed serious complications, including radiation burns, rectal bleeding, bladder problems, and 1 patient died from the complications related to the overdose. And again, human error, incorrect commissioning, lack of independent audit, and the lack of training. So, how do we learn about our equipment? How do we make sure that it does what we really want it to do? So, let's come to the basics. And actually, we do have some guidelines and from International Atomic Agency, for example, and which states that registered and licenses, in addition to applying the relevant requirement for quality assurance specified elsewhere in the standards, shall be established. So everyone needs to establish a comprehensive quality assurance program for medical exposures. And that's the recommendation of WHO and the WHO. So obviously it comes to the countries to implement these guidelines, but everyone should have a quality assurance. And what it is, it obviously is all the planning and systematic actions necessary to provide adequate confidence that a product, a service will actually deliver, satisfy the given requirements for quality. And in radiotherapy and brachytherapy as well, of course, all procedures that ensure safety and consistency of medical treatment goes under the quality assurance. And we have quality standards that help us actually to establish quality assurance, like World Health Organization from 1998, updated in 2013, International Organization for Standardization, and we also got a more local quality standards given by APM, STROS, and other national agencies. So we do have tools to actually establish this kind of safety protocols in our clinic. So how does this normally look like? So when we've got our brand new equipment in clinics, what we supposed to do, according to most of the guidelines, is first acceptance of critical examination. So basically, we first kind of assess that the equipment that we received from the manufacturers were exactly what we ordered. So there's no surprises there. And the critical examination that actually does what it's supposed to do in a kind of a first glance, and that the radiation is in a safe place and in a safe manner, kind of all the interlocks working. Then we've got a commissioning of our equipment. So that's the time when we actually do all the measurements, all the baseline that we later on use as a baseline for our quality control or quality assurance program. There's a time when we actually learn about our equipment. There's a time that we actually have to really familiarize ourselves with all of the aspects of the equipment that we just received. Then we also have to commission of all auxiliary systems like treatment planning software, which obviously, if we don't do it correctly, whatever we put into the electronic system is going to be incorrect, like garbage in, garbage out situation that has been well described in a treatment planning software commissioning documents. And then having that, we obviously have a quality assurance program that we have to establish. So all the procedures, standard operating procedures, working instructions, frequency of the tests, how we're going to do the quality assurance, and all these things need to be documented. Then we should have independent audit or independent check of what we actually have done. That comes that even though we actually try to do our commissioning to the best standard we can actually we do, there's always a possibility that we missed something. We just made a mistake, a human error. It happens, as it was, clearly shown in examples previously, that sometimes does not go according to expectations. And it was actually not a long time ago situation in the UK when the external or independent check actually showed that the commissioning of the LINAC was inadequate, and actually this LINAC was not accepted for the clinical use, and it had to be recommissioned. So it's a very important thing actually to have someone independently check the work that we've done. Then we obviously need to train the clinical staff, technologists, technicians, radiographers, clinicians, anyone who's going to use the equipment, and hand over to the equipment to them. And then obviously, when we're using the equipment, we have to have a clinical checks in place. So basically test ongoing plans and ongoing treatments, that there's no malfunction of the equipment during the treatment, or everything is in order when we actually do treat the patient. And we've got the quality control to ensure that the equipment is still performing as at the time when we actually did commission. And the last thing, we've got a clinical audit. So basically, that's kind of every so often we want to check that the equipment is still doing what we expect it to do, and is it actually what it does with respect, to the equipments, with respect to other equipment or the same kind of equipment in the country or in the world, to actually see if we deliver the quality treatment with our equipment. In brachytherapy, for example, it's very important to know the source localization. It is because the dose gradient actually are very high in brachytherapy. It's just a reminder that 8% per millimeter at 2 centimeters from source. And there is a just comparison with external beam therapy, where you actually can see that the steep dose gradients are much, and that the dose gradients are much steeper for the brachytherapy. So, for example, the impact of 3 millimeter difference between the expected and actual source position within the applicator, so the applicator is in the right place, can actually lead to quite big errors in the expected the dose delivery that we expect with respect what we actually do achieve. So, for example, the difference up to 7%, 3%, depending on what kind of a structures and what kind of a plan it is, but they are not insignificant, and it actually may change from what is acceptable plan to what is really not acceptable plan. Sorry. It's even more pronounced when we actually look at the impact of the applicator shift. So if we do not reconstruct the applicator in a correct place, that actually 1.5 millimeter shift of the position of the applicator with respect where it really is can lead to the very similar errors of around 6 to 7% on the actual dose delivery. So it is very important to know where are the sources, for example, during the brachytherapy treatment. Obviously, there are other aspects of the brachytherapy commissioning, like the source trends and the source model and treatment planning software and all the other aspects of the commissioning needs to be checked as well. So, for example, to show why the commissioning is important, I'm going to show some examples from where we actually did commissioning of our equipment, of various equipments in brachytherapy. So, for example, that was one of the first tests that we've done in one of the HDR units, and we discovered during the source position dwell change, it doesn't change according to expectation. So we were supposed to move them in the known distances, whereas when we actually checked them on a film, they was not exactly the same place we were expecting. So this one was when the transfer tube was absolutely straight, and this one was when this transfer tube were actually curved. So the difference between those source positions in a straight applicator were actually 4 millimeters. And that was due to the wire tension in the transfer tube that was actually curved. And so that was actually said to the manufacturer, who did create kind of a compensation algorithm for that. The another error that we actually discovered was the record and verified system failure during the unintended switch off test. So HDR control PC was accidentally switched off during the test, and delivery actually carried on for 20 seconds after the control PC was switched off, and the source retracted after that to HDR unit. We restarted the PC, and there was no record of additional 20 seconds of exposure in the system. And that was actually due to the manufacturer's software failure. They didn't envisage the PC going off during the aviation. So that was actually something that stopped us to release equipment to clinical use, and manufacturers actually had to act and change the software to make sure that before we actually go live, this won't happen. Another example, during the upgrade of our treatment planning software, there was a various of the data source changed during the update, and that actually led to quite a bit of a difference in expected dose, 3 to 4%. And on top of the actually radial dose function being different, dose rate constant being different, and the half-life of the cobalt being different, there actually was also changing titanium attenuation factor by 3% between the version of the treatment planning software. So again, quite a big difference. What is very important during the commissioning of the brachytherapy equipment is actually commissioning your applicators. So, for example, there are a number of different gynecological ring applicators, or ovoid applicators, and actually commissioning them is often quite tricky, because it's not that easy to know where your cells are supposed to be and where your cells actually are during the treatment. So reason being that actually the difficulty is also because what happened is the source path, obviously the RIP applicator is very curved. And what it does is send the source to the, actually the curvature causes the source cable to behave in a very difficult to predict manner. So for example, when the source is actually being fully sent to the first position, then we want to retract it by 1 centimeter. We should have the source 1 centimeter behind the first position. And actually, when we do that, it's probably ½ centimeter different. It's because the wire tension changed during the retraction of the source. So what we've done when we were commissioning our ring applicators recently, we actually created the jig that was quite precisely manufactured. That is a prototype on the images here, but it still was very precisely made, and which allows the orientation the both applicator and the film to make sure that we know the direction and know the orientation of the film with respect to the applicator. We created the Python script that actually allows us to mark the source positions, and we tested that for the single and multiple operated consistently, and it was actually within ½ millimeter differences between the different operators for the same source positions. So then we actually did the all our applicators. We got 6 of them, 5 times each of 5 times. We measure each applicator 5 times, and then and on this basis we actually established that there's no difference between the applicator itself, and we kind of mark the average source position when we would retract that 5 millimeters step sizes. So that's what we actually got. That's how the source behaved within the ring applicators. However, the model of the applicator within the solid model library looks like that, which is a very nice, evenly spaced source nominal positions. And when we actually move one to another, you can actually see that the source measured and the source from the solid applicators do not match each other. You may think that actually, some of them do, but actually this source position corresponds to this actually nominal source position. And the same here, this source position is actually responsible for this nominal source position. So it's more than 5 millimeters discrepancy between the nominal positions of the source in the solid model and what we've measured during the commission. So manufacturers actually allowed to adjust that path, and that's what we've done within the trip planning software. However, you cannot save that in the solid model library. So there's another complication. We have to actually create the template plans and actually use the template plans for our treatments. So you can see that we actually squeezed the source positions in our new model. And when we actually overlay the new model over the source measurements, you can actually see that they correspond to each other quite well. So we managed to kind of reduce the error of the source position to less than 1 millimeter, and that actually was quite consistent with the repeated measurements. And that would be the end of the story. If not, the manufacturer actually released a new version of the software, where they introduced the different types of the applicator components, like flexible, needle, rigid, and ring. And that was the release note, exactly how is it said here, and was nowhere saying that you have to recommission your ring applicators if you want to use the ring type. So but we actually did test that just to make sure that everything is in order. And what we actually found is, so when you see the old for the previous version of the software, which we saw this picture before, and then we take a new version of the software positions, there were more than 2.5 to 3 millimeters difference between them. So again, had we not tested it, we would be more than 3 millimeters off on our nominal source positions. So we thought, oh, that actually looks much better than it used to. maybe the solid model now would actually work with our system, and we don't need to have a template plan. So we did test again, and what did we find? That no, even though they introduced a new version of the software and they changed the way they actually do the correction for the big applicator, it's still nowhere near good enough to be used for clinical use. Because you can see that this source actually corresponds to this source nominal position. Again, more than 3 millimeters difference. So we had to do the same as we did previously. We just change our path in the software and say that is our new template. And now again, we've got something that is about 1 millimeter difference in a worst case scenario from the nominal positions. So in UK, in one of the centers in 2020, with exactly the same ring, people actually choose to have a different approach and use the kind of an offset to the source positions, and use that as a clinical way of compensating for the different positions of the source in the nominal solid model and the measured source positions. What happened was that during the treatment, a combination of this offset for the first source position in treatment planning software and the measured first position in HDR do not match. Therefore, the HDR unit decided to cut first source from the plan. So error was actually discovered in the second fraction, and the plan was compensated for that. So fortunately, the patient did not suffer mistreatment. But for 2 fractions, there was basically a completely different plan in the treatment planning software, the plan being delivered in the on the treatment unit. So again, it actually shows how important it is to make sure that you know what your equipment is doing in all of the kind of clinical situations. So now the audits. It is important to take part in audit because they actually show how you deliver your normal standard clinical treatment, or at least as close as it is. Even though you do your commissioning, you have independent checks, you're doing everything right. But then someone says, okay, let's try to do some tests. Let's see how we're doing. And in Japan, on the because of this incident that I mentioned in the first slide, they decided actually to test the centers to see how they do deliver the treatment and what are the differences. And they designed very simple end-to-end audit with a polymer gel dosimeter, and it was CT imaged, 1 single straight catheter, and the testing criteria was gamma 95% at 5%, 3 millimeter global gamma. And the plan was simple, just 4 source positions, 20 millimeters from the applicator tip, and then 20 millimeter, 10 and 10 millimeter source positions, 10 millimeter prescription point, which is supposed to give this kind of a dose distribution. And 35 centers in Japan took part in this audit, and only 23 centers passed this simple test. And the errors that were identified was incorrect tip offset, magnitude or sign up to 23 millimeters in the worst case scenario, dwell position error, misidentified catheter tip on treatment software infrastructure, CT artifacts and incorrect data entry for the treatment software, errors more than 5 millimeters, incorrect dwell weight prescription dose, incorrect unit of prescription dose, centigrade to grade, 100 times wrong, incorrect prescription point dose location. And the authors actually said that the results of study highlight the potential risk that large source positional errors exist in the dose delivery in brachytherapy in clinical practice, and they assume that the similar mistakes may occur during the treatment plan in clinical practice. In Portsmouth, we also did the multi-center end-to-end audit. So basically, Professor Palmer was leading that, and the Portsmouth was actually lead center for this audit, and it was done between 2005 and 2006, and it was much more clinical-like audit. So we had solid water phantom with 4 different plain EBT3 films, in this phantom. The phantom was in water, and the applicator that it accepted was a gynecological applicator with a tandem or ring and the IU tube. And the comparison was made between the A points and the isodoses on EPT3 film. Only not needles, only the simple plants were delivered with the prescription 7-weight.8. So that's the results, and the mean percentage dose on the point A was about -0.6% and -3% for the metal applicators, and the distance to agreement was about 0.5 to 0.7 millimeters. So actually not that bad, but there were centers that were about 6 and 5% off in the point A prescription. And looking at the gamma passing rates, when we actually look on the isodose distribution on the film, and 5% and 3 millimeter and 3% and 2 millimeter gamma criterion, and with the two-way lower cutoff, so not take the very low dose into the account when looking for the gamma criterion. And that was not too bad, because 5% 3 millimeter, you can see on the top row, almost all the center passed. But 3% 2 millimeter, there were some centers that actually only get 80% agreement. So it's not that everything is always correct, even then you know, someone tried to actually deliver the best treatment. There is a multi-center IEAI audit in preparation, and the pilot study was done in 2022 in the UK. There are some results, but I don't have them. But the design of the audit is very simple. They have two catheters that go in parallel to each other. There are a number of sources along the catheter to create fairly uniform distribution in the center, whereas the glass rod dosimeter to check for the dose. And there's also a place for the film to actually check the source positions in the catheter. So that's going to be rolled out, I think, worldwide, so it will be worth taking part. So in summary, to ensure the clinical safety and correct patient treatment, knowing your equipment is critical. And we do have some tools for that: commissioning, training, quality assurance, clinical checks, independent checks, and independent audits. But we have to remember, do not blindly trust the manufacturer. You have to test your equipment yourself and then test it again. So thank you very much. I hope it was interesting. And if you do have any questions, I can always ask. Thank you very much.
Sir Polak, can you hear us?
Sorry, it seems like we can't hear you, Bojek. No, it's not working still. Can you hear me? Sorry, can you hear me, Bojek?
Please disconnect the audio and reconnect the audio again.
No, we still can't hear
Try
you.
using the
Hello?
mic. Oh, yes,
Hello?
we can hear you now.
Yes, we can
Okay,
hear you now.
thank you.
Yeah, yeah.
That's fine. I'm sorry. Yes, I was thinking I'm going to deliver the talk myself, not the recording, but yeah, it was what it is anyway. So yeah, if anyone's got any questions, I'm happy to answer.
So the physics team in the room, hopefully they have some questions for you. No? Thank you very much.
Mr. Pollock.
Yeah.
I'm Ghada Rifat. I'm very happy that we finally met. The presentation, so sorry, there was some sort of a technical difficulty, and after starting of the recording, they couldn't, for some reason, to stop it. So sorry for that. We want really to face ask you many questions. I have a question myself. That we now face some sort of toxicities like rectal or vaginal toxicities. We somehow review our AQD2 for these organs, and we found sometimes it's maybe exceeding the dose, and maybe it is okay. So in the topic of the presentation, sir, is the commissioning have a role, or the QA has a role in maybe we have some uncertainties we don't know and we are not yet aware of, that may cause some toxicities, and how can we avoid?
Well, as I shown on the image, knowing where your source really is probably one of the most important things when you commission your machine. And few millimeters errors can actually lead to increase or decrease the dose with respect to where you intend actually the dose to be put in. But that's obviously, that could be a reason, doesn't have to be a reason. The other reasons may be imaging, it may be actually the outlining by the clinician of the organ at risk as well. And I don't know if you do your outlines on the MR imaging or on CT imaging, because
It's CT.
it's a CT imaging. So quite often before we switch to actually doing the MR imaging, the high-risk CTV that is drawn on the CT imaging only is quite often a little bit bigger than it would have been on the MR imaging. And that actually also can play a role when you're trying to optimize to that, that you will see a little bit higher doses to your organ risks. And it can be also the combination of all of those factors as well, to be honest. So it's difficult to say, but I will definitely review if your reconstruction of the applicators within the system when you're planning, and where are the sources during the plan, I would try to review and see if you actually do not have any kind of misalignments or discrepancies between true source position and treatment source positions in a treatment planning software, basically.
I think they're on mute actually now.
Yeah, that's great.
Thank you. This is a very important point, and I think one of the issues actually one want to highlight, because now they're using interstitial needles, so that's actually, it's more of a reason to try and make sure that the reconstruction of the applicators on the system and the commissioning of the applicators are actually quite well known and well done, because it can be a reason why there is a hidden understanding of what the dose. I think you think that you've actually met the constraints, but you may have not, and the system could show you that you have, but that's false information. Yeah,
definitely, and that's probably if the ring applicators you need use, it's even more complicated quite often and more difficult. But also the manufacturers put like a lot of compensation in the system that they should actually make the system to be more accurate. But you have to understand how those compensations are applied again. and how they actually influence your treatment planning software dose.
Because likewise, I guess the problem that can happen is that it can happen the other way around, that you're actually thinking that you're achieving the dose to the HRCTV, and yet the dose is lower than what you'd expect. The system tells you, again, on the computer, the calculation seems fine, but in real life, it may be that the dose to the HRCTV is a bit lower than what you've expected because of the compensations on the system already, on the applicators, for that reason.
That can happen, definitely.
Yeah. Thank you.
Any other questions?
Can I just say that I think you're on mute in the room, so we can't hear you if you're talking to us. It seems like it's just me and Wojciech on the call, but it doesn't seem we don't seem to have you guys. I think it says here red, so I think you're on mute at the moment. Yeah, you've unmuted yourselves. Yeah.
Yeah, okay. Hello, Dr. Black. I am Noha, physicist in our breakthrough team in Ain Shams University. I have two questions. My first question is regarding the ring applicator commissioning. How I can calculate alpha angle. My second question is regarding the Fletcher reconstruction. When we do the plane using the Fletcher, it usually give us bad results.
So the question again, it was very difficult to hear you. Sorry, probably the mic.
Noha, did you say how to calculate the alpha angle?
Yeah, in ring applicator commissioning.
On the ring applicator commissioning, how can they calculate the alpha angle?
You mean the angle for testing where your source actually really is, you mean, or to compare it with the TG43?
Sorry.
So, Noha, do you mean to commissioning as in where the source is, or is it
to compare with the TG43?
No, for 3D.
Oh, for 3D. Okay. I will definitely use the GAF chromic film and do the loads of measurements, trying to overlay where the source is actually being sent in real life with respect to what the treatment planning software thinks, like I showed in my slides. So basically there can be up to 5 millimeter differences in the ring applicator. So if you do not exactly know where they come, there can be quite a bit of an error in delivered dose because of that. And obviously the impact of this error will be different on the different patients because, you know, every patient is different. But actually knowing this inaccuracy is very important when you're using the ring applicators. That's why actually quite many centers were very reluctant to use ring applicators because of this reason and opted for the ovoids, for example.